Dr. Robinson earned her undergraduate degree from Princeton University and her medical degree from Tufts University School of Medicine, subsequently completing a residency in neurology at the Mayo Clinic in Minnesota, where she was appointed as the chief resident. She pursued a fellowship in hospice and palliative medicine at Memorial Sloan Kettering Cancer Center and returned to the Mayo Clinic in Florida for a neurohospitalist fellowship. She was awarded a postdoctoral fellowship in health services and health policy research through the Robert Wood Johnson Foundation's Clinical Scholars Program at UCLA, during which she earned a Master's of Science degree in health policy and management and engaged in research focused on the intersection of neurology and palliative medicine. Dr. Robinson has spoken nationally and internationally on neuropalliative care. She edited a book titled Case Studies in Neuropalliative Care, and she is a member of the American Board of Internal Medicine, Hospice and Palliative Medicine Exam Question Approval Committee. She is also very active with the American Academy of Neurology, currently serving as the chief member of the Engagement Committee and an ex officio member of the Board of Directors. Welcome, Dr. Robinson.
Thank you so much for having me. I'm across the pond in Jacksonville, Florida, and really delighted to be here. So let me get my slides up here for us. Excellent. So this is going to be a brief talk on pain management in oncology. I have nothing to disclose. We're going to spend a little time talking about how to choose opioids. We'll look at some analgesic dosing principles, and I have a brief case that I'll share at the beginning just to get us started. We don't have a lot of time, so this is going to go fast. So Ms. Jones, a 54-year-old woman, she has a history of metastatic ovarian cancer. She's already undergone a total abdominal hysterectomy and bilateral salpingo-oophorectomy. She's presenting with abdominal pain that she describes as constant, achy, located in the right upper quadrant, and it is significant, 8 out of 10. A CT scan of her abdomen and pelvis shows some omental studding and new liver metastases. So when I think about how to take a history for somebody that has pain, the first question is, where is it located? She's telling us it's in the right upper quadrant. The second question is, what is the description of the pain? She says achy pain, constant pain, and we can sort of try to determine, is this nociceptive pain or is it neuropathic pain? Most people know neuropathic pain, right? That's the burning, stabbing, shooting pain that people may describe. Everything else is nociceptive pain. There's nociceptive somatic pain affecting, for instance, muscles, tendons, limbs. Then there's nociceptive visceral pain, which affects the visceral organs. Then the question becomes, what is the profile of the pain? Is it changing? Is it constant? Is it breaking through some prescribed regimen that they're already on? Is it sort of intermittent, coming and going? Or in this case, she told us it is constant. What's the severity of the pain? Some people don't like this. We don't want to deal with the pain scale. But when you're taking care of a patient, their pain scale actually can be relatively valid because you're asking them to rate their pain sort of as time goes on. And so you can rate it based on how they're describing it. So she says 8 out of 10. And then if people are on other medications or other therapies, you can try to say, have those been beneficial or have they not? Another way to think about the assessment is a mnemonic that I learned in medical school, old cards. So when did the pain start? What was the onset? Where is it located? Is it localized? Is it widespread? What does it feel like? That's sort of the quality and intensity. We ask about the duration. Is it constant or incidental? What are the things that make it better or worse, right? So those are aggravating and relieving factors. How has it responded, I just mentioned, to any other regimens that you've tried? The other thing that I think is very important is how is this pain interfering with your current daily life? What can't you do now because of the pain? Because I want to know that because if I help the pain, they should be able to do some of those things that they can't do right now. And then what comes along with the pain? Are you tachycardic? Are you flushed? Are you nauseous with the pain? Are you having headaches? Are you depressed? What other signs and symptoms are going on when people are having the pain? I don't have to tell this group this, but I'll just mention it briefly that we know pain can negatively impact people's function completely. The way they move, the way they think, the way they concentrate, the way they're able to eat and sleep, and it can affect their mood. And this can result in the way they show up in life, the way they engage with other people, the way that they care for other people and care for themselves. So we really have to focus on trying to alleviate pain, particularly in our patients that have cancer. So back to our lady that we discussed, I mentioned that she has nociceptive visceral pain because it's in the abdominal area. And so we are now going to try to figure out how can we help her. So how do we choose our pain medications? Well, the World Health Organization has this ladder that they've organized with regard to relative medication strength. So the first step on the ladder, we think about weak pain medications, weak analgesics. Many people think about aspirins or paracetamol, also known as acetaminophen, the nonsteroidal anti-inflammatory medications, and then plus or minus adjuvants. Adjuvant medications tend to be medicines that will work for pain, but weren't initially designed for pain. So things like anti-seizure medicines like gabapentin is a common one that people may use, or steroids, which can be used for pain, although those medicines weren't initially designed to manage pain. The second step on the ladder would be moderate medications with regard to strength, codeine, tramadol. And then we see these combination medicines. So the paracetamol and codeine, or paracetamol and tramadol, paracetamol and hydrocodone, paracetamol and oxycodone. And then we can't forget our adjuvants. And although it's not on this letter, I will add that you can also continue to think about adding aspirin in this situation or NSAIDs as well, as these medicines all work in a bit of a different way. And then we get to the third step on the ladder. These tend to be our stronger opioids: morphine, oxycodone, hydromorphone, fentanyl, methadone. And then also we remember our adjuvants, and I'll add again, aspirin and NSAIDs can be added here as well. So where do you start on this ladder? Well, I mentioned that they were grouped based on relative strengths. Our patient told us her pain was 8 out of 10. And so she has severe pain. You'll see for mild pain, we tend to think about 1 to 3 out of 10. For moderate pain, we tend to think of 4 to 6 out of 10 in terms of severity of pain. And Our Lady is within the 7 to 10. And I'll say plus because some people will say, my pain is 15 out of 10. But this lady said 8 out of 10. So she has severe pain. Anytime we're thinking about pain medicines, we always have to remember the potential adverse effects or side effects for these medicines. The common ones for opioids, at least, tend to be constipation, nausea, vomiting, and sedation. But there are others. Some people may complain of itching or dry mouth or sort of seeing bugs crawling around the room. Sometimes I'll ask that and say, Dr. Robinson, what do you think? You think I've gone crazy? But I throw that in because every once in a while, somebody will say, yes, I have been seeing bugs around the room. And I say, well, that's your pain medication. If it's bothersome to them, we may have to rotate medicine. But some people will say, I know they're not real, and I'm okay now knowing that it's just a side effect of medication. But there are, some other ones, urinary retention as well, that we may ask about, confusion too. So when we think about dosing principles, let's start here. First order kinetics. These are medicines that have a predictable response to dosing. So you give the medicine. When the concentration increases, pain gets better. As the concentration decreases, people tend to tell you the pain returns. And so here is the schematic for it. You take the pill, let's say, pain improves. As the medicine goes out of the system, the pain may come back. And so this is time, you see, on the x-axis, and the concentration of the medicine on the y-axis. So when the concentration is high, pain is better. As the concentration decreases, pain comes back. First order kinetics, predictable response. This is most analgesics except methadone. These are often the medicines we use in palliative care. We just heard an excellent talk a second ago about palliative care in general. And one of the things that I mentioned was the need to provide adequate symptom and pain relief. And so when we're thinking about medicines of palliative care, most of these medicines will follow first order kinetics. And there's certainly a risk of side effects. So once we give a medicine, we'll monitor the response. If people are needing extra medicine, so beyond their usual regimen, we call that a breakthrough pain, and they need a breakthrough dose of medicine. We offer that every Tmax as needed. So you might be saying, okay, Dr. Robinson, what's the Tmax? Well, I'm glad you asked. I'm going to introduce two concepts here, a Cmax and a Tmax. The first is Cmax. So Cmax really means the C is concentration, max is maximum. So the analgesia is greatest at the time of maximum concentration. So when the highest amount of medicines in the system, the patient is going to have the best pain relief. You can probably imagine that the time that it takes to get to that maximum concentration is the Tmax, right? So Cmax is maximum concentration. Tmax is time to get to that maximum concentration. So Tmax, you'll see right here, is aligned with Cmax. So we're going to spend most of our time talking about morphine today. So I'll illustrate here with morphine, depending on the route that you give it, the Tmax will vary. So oral morphine, the Tmax will be about 60 minutes. It takes about 60 minutes to reach the maximum plasma concentration. If you give it subcutaneously or intramuscular, it'll take about 30 minutes. If you give it IV, 15 minutes. So certainly IV is the fastest, but you'll also see the concentration drops the fastest, right? So it gets into the system fast, but it doesn't stay. The oral takes longer to get in the system, but it stays longer. So principle one, I mentioned this briefly a second ago, but now that we've introduced these new concepts, I'm going to say it again. For extra or breakthrough pain, so pain that's breaking through somebody's usual pain regimen, you offer an extra dose every Tmax as needed. The patient can say, no, I don't need it, but it's an as needed dose that should be available. The other thing I want to emphasize is that for somebody that is opioid naive, never been on pain medicines before, opioids before, we use these short-acting medicines that have a predictable response. We don't use extended release opioids. So, breakthrough medicines are given in every Tmax as needed. So morphine, we talked about oral morphine or rectal morphine, it takes about 1 hour to reach the Tmax as the time at the maximum plasma concentration. So after 1 hour, a patient would have an available dose of morphine that is for the breakthrough pain. And they can say no. For constant pain, we dose it every half-life routinely. So let me talk about half-life now. So half-life is the time it takes for the body to eliminate half the dose. So if you give a 10 milligram dose of morphine, in order for you to get to 5 milligram when it remains, half of the dose eliminated, right? And so you're trying to see how long does it take for half of the dose to be out of the system, eliminated from the body. So for morphine, all routes, it's about 4 hours. Half of the dose is gone in 4 hours. So 5 milligrams would remain. For constant pain, we give medicine every half-life to achieve steady state. So if we dose oral morphine, which has a half-life of 4 hours, you'll see that it takes 5 half-lives to achieve steady state. So the first dose is given at 4 hours, you give another dose. At 4 hours, you give another dose. And you keep going until you have 100% of the medication available. This matters because we want to find the sweet spot where a patient is not having too much of the medicine, where they're getting a lot of side effects. We're trying to find the sweet spot where they're not having too little of the medicine, where they're having terrible pain. But we want to have enough medicine constantly in the system so that pain is well controlled. And so that is the space between too high of a concentration, too low of a concentration. And so that's sort of the steady state. There are some peaks in there and some troughs in there, but the pain is reasonably well controlled. So although I'm going to focus mostly on morphine, I did want to provide a few starting doses for some other medicines that you may want to use. The first would be paracetamol or acetaminophen. You start at 325 milligrams every 4 hours. The maximum would be 650 milligrams every 4 hours, just thinking about liver protection. And the steady state for this is also 20 hours, so 5 half-lives. Ibuprofen, 200 milligrams is a good starting dose every 4 hours. The maximum is about 600 milligrams every 4 hours. Again, steady state is achieved in about 20 hours. Back to the morphine immediate release. The dose could be variable, but as I mentioned, you can give it every 4 hours. Tmax is 1 hour. The half-life is 4 hours, and steady state is about 20 hours. Now, tramadol is a little different. Starting dose would be about 50 milligrams every 6 hours. The maximum is 100 milligrams every 6 hours. And so the Tmax for tramadol is 2 hours. And the half-life is 7 hours. And it takes 30 hours to reach steady state in this situation. Okay, so let's talk a little bit about what we're going to do for this patient with regard to a morphine dose. So she told us her pain was 8 out of 10. She has not previously been on analgesics, which is opioid naive, meaning we want to start with short-acting medicines. We can think about morphine 10 milligrams or 15 milligrams, and we will dose it every 1 hour as needed. And so if they're a patient that you're taking care of is maybe elderly or frail, you could consider reducing the dose 25 to 50% or so, particularly if you're concerned about the potential effects. So in this type of situation, what as needed dose could be used? We talked about for extra breakthrough pain, we can provide an extra dose, which is usually 10 to 20% of the total dose that they've gotten in 24 hours. Okay. Or you can add up the 24-hour dose and divide by 6. You'll get a dose that is similar to the 10 to 20% of the total 24-hour dose. And so you can approach it either way. And you offer that every Tmax as needed. And of course, the patient can refuse. And for morphine, that's going to be every 60 minutes. For this lady, we're going to give her a routine dose of morphine immediate release. That's the IR, 15 milligrams every 4 hours. So her total dose in 24 hours would be 90 milligrams because she's getting 6 doses within 24 hours. So if I said 10 to 20% of that for her as needed dose, I could get somewhere between 9 and 18 milligrams because morphine comes in 15 milligram tabs or 30 milligram tabs. We say her as needed dose is 15 milligrams. Okay. So we added up her 24-hour dose, which is 90 milligrams. We get 10 to 20% of that to figure out her as needed dose, which would give us somewhere between 9 milligrams and 18 milligrams. And because morphine comes in 15 milligram tabs, she'll get 15 milligrams as her as needed dose. So before we give the as needed dose, we want to make sure we recorded the dose that we've given. We ask about pain severity, and we ask about any adverse effects. How are you feeling with it? Are you confused, too sleepy? Are you constipated? Are you seeing any bugs crawling around? Are you nauseous? And then making sure that that is documented. So let's play around with this a little bit. This is just a little clock that we're going to provide some dosing around the clock for. So if we start her medications at 10 a.m., we've decided we're going to start at 15 milligrams for her routine dose, and she can get it every 4 hours. And that would be scheduled because she has constant pain. So scheduling 15 milligrams of morphine every 4 hours. So she would get it at 10 a.m., and we would anticipate that she would get it again in 4 hours, which would be 2 p.m. So we'll start at 10 a.m. And then we say, do you have pain in 1 hour, right? Because that is the Tmax. So do you have pain in 1 hour, 11 a.m.? And we offer her the breakthrough dose that we calculated as 15 milligrams of morphine. So there's an option for her to take it at 12 o'clock, there's another option to take an as-needed dose of 15 milligrams. At 1 p.m., there's an option 1 hour later to take another 15 milligram dose. I think you're following this now. And then if we say at 15 milligrams is her constant dose every 4 hours, and we've given her 15 milligrams as the breakthrough dose as needed. If she's still in pain at 2 p.m., how much can she have? And I mentioned to you that at 2 p.m., that's her scheduled dose. But don't forget, she can still get the as needed 1 hour dose. So potentially, if she were still in pain, she could have 30 milligrams. The 15 milligram standing dose is not negotiable. She should take that. But if she says, my pain's kind of under control, she doesn't have to take the as needed 15 milligrams. So I'm hoping everybody's following this. So we started her at 10 a.m. with a 15 milligram scheduled dose. Because she has constant pain, we will schedule 15 milligrams of morphine every 4 hours. If her pain breaks through, so remember that graph that showed she had pain and there's a breakthrough. If her pain breaks through this 15 milligram regimen every 4 hours, she has an option to have an as needed breakthrough dose every 1 hour, because that's our Tmax. That's when the morphine is reaching its maximum concentration. That's when we give our breakthrough dose. So you'll see on this clock, every 1 hour after 10 a.m., she has the option of getting an additional 15 milligrams. And we found that additional 15 milligrams by calculating her 24-hour dose of the scheduled morphine. 15 milligrams every 4 hours. So 15 times 6 times a day is 90 milligrams. Taking 10 to 20% of that is 9 to 18 milligrams. Morphine comes in 15 milligram tabs. That's how we got our 15 milligram breakthrough dose. So she has the option of that 15 milligram breakthrough dose every hour after we start the medication, including on the hour when she gets her scheduled medications. So this is sort of an example of what a pain diary might look like at 10 a.m. She told us her pain was 8 out of 10. We gave her the 15 milligrams scheduled. At 11 a.m., her pain is a little bit better. It's 6, but it's still there. So we gave her the PRN 15 milligrams. At noon, she still has pain. She got the PRN 15 milligrams. At 1 p.m., pain is still 5 out of 10. She got the 15 milligram as needed. At 2 p.m., her pain is 6, and she wanted the as needed medicine. And then we also gave her scheduled dose of medication. So initial dosing, we dose based on the pharmacokinetics properties that we discussed for the first order kinetics. We try to figure out, has it been helpful for her? And we think about the safety of the medicine. Any opioid calls for us to safely prescribe it. It doesn't matter about the dose. A low dose could also be unsafe in some people. So we want to make sure that we're being very, very careful as we're prescribing opioids in general. So we think about the efficacy, is it effective, and the safety of the medications. And then we also want to anticipate common side effects. Most commonly constipation or nausea, but I sort of showed the entire list of potential adverse effects. So for some people, like for this lady, we'll have to think about what are we going to do long-term for her if she's needing really medicine around the clock. So I mentioned that people are opioid naive, we would only start with short-acting opioids. Once people have taken short-acting opioids for a prolonged period of time, they're no longer opioid naive, right? They've become tolerant of opioids, so they're opioid tolerant. Then we can think about adding an extended release medication like morphine extended release. So morphine IR was morphine immediate release that we were just talking about. Morphine ER or morphine extended release is provided in a capsule form that has a slow release of medicine over time. And you start the dose based on what the demonstrated need would be. So we could calculate her 24-hour use of morphine. So we know we were already giving her 15 milligrams of morphine every 4 hours, and so that's 90 milligrams. But then we have to add up all the as needed doses of 15 milligram that she got as well. And that would give us our total 24-hour dose. And then we can use that to determine how much should we automatically give her every 12 hours. It's a scheduled amount in the morning, a scheduled amount in the evening. Some people would take 50% of that total dose and break it in half and just give it to her automatically in the morning and in the afternoon. Others would take more, 80% of it. So some of this has to do with your comfort level. The Cmax for these extended release medications is about 2 to 3 hours for morphine. We dose it every 12 hours, and it takes about 60 hours to reach steady state. So you see, we're dealing with a little bit of a prolonged time to get the maximum concentration into the system because it's a time release formula, and it takes longer to achieve steady state. So the last thing I'll just mention is that we want to anticipate side effects, and you want to prescribe for that. So there are many medicines you can give for nausea, some that are easy to get, maybe haloperidol. We think about constipation as well. Senna, 1 tab twice a day to start. Think about other medications, not only the Senna, but osmotic as well. Laxatives like polyethylene glycol can be used, or lactulose can be used also for that. So this was a fast presentation, but I hope you got a little bit of a primer to how we think about medications, particularly for pain in patients with cancer. We're thinking about some of the stronger opioids for many of these patients, about how to start finding the medication to use, thinking about some of the pharmacokinetics of the medicine, and how we continue to titrate. So I borrowed some of these slides with permission from the Palliative Care Interdisciplinary Curriculum, so I want to thank them for the opportunity to utilize some of these slides and to provide some acknowledgments here as well. Thank you so much for the opportunity. I think we'll have a moment at the end for questions.
Thank you very much, Dr. Robinson, for a very well delivered lecture, very informative and very educative.